All right, so welcome to this deep dive, everyone. We are going to do a really in-depth review of brachial plexus injuries and really try to give you the key facts that you need to know as you prepare for your plastic surgery boards.
That's right. This is going to be a high-yield session for everyone out there studying and trying to refresh on this really important topic. We'll be covering anatomy, classification of injuries, patient evaluation, and then the key principles of both non-operative and operative management.
Okay, perfect. Let's just dive right into the anatomy.
Sounds good.
So when we think about the brachial plexus, what spinal roots are we talking about?
Okay, so the classic teaching is C5 to T1. Those are the roots that make up the brachial plexus. But keep in mind, you can have some variation. You can have what's called a prefixed brachial plexus,
Okay.
where you have contribution from C4,
Uh-huh.
and you can have what's called a postfixed brachial plexus, where T2 is involved.
Yeah.
But the vast majority of people, C5 to T1.
Okay, perfect. And so those roots then emerge where in relation to the scalene muscles.
So you're going to see those roots emerge between the anterior and middle scalene muscles
Okay.
in your neck. And right around there is where you're going to get those first couple of branches coming off the roots. So you're going to get the long thoracic nerve, which is going to innervate the serratus anterior.
Yep.
And then you're going to get the dorsal scapular nerve, which is going to go on to innervate the rhomboids and the levator scapulae.
Okay, great. And so then those roots then converge to form the
Yeah.
trunks.
That's right.
Right. And so we have 3 trunks.
3 trunks. You have an upper trunk, a middle trunk, and a lower trunk. And those are all located in what we call the posterior triangle of the neck.
Perfect. Great. And as they pass through the posterior triangle, are there any branches that come off of the trunk?
Yeah. So you're going to get the suprascapular nerve coming off of the upper trunk.
Yeah.
And that's going to innervate the supraspinatus and infraspinatus. Very important for shoulder function.
Yeah.
And then you also have the nerve to subclavius, which comes off of the upper trunk.
Okay, great.
Yeah.
And then those trunks then continue on to become the divisions.
That's right. So each of those trunks is going to divide into an anterior division and a posterior division. And this is all happening as they're passing under the clavicle
Okay.
and deep to the pectoralis minor muscle.
Okay, perfect. So we have the trunks splitting into anterior and posterior divisions. Do any nerves come off at the level of the divisions?
That's a great question, and it's a classic board question. No peripheral nerves branch off the divisions.
Okay, perfect.
Yeah.
All right. And then our divisions finally converge to form the cord.
Chords. Okay.
And you have 3 cords. You have a lateral cord, a posterior cord, and a medial cord.
Okay.
And they're named that way based on their relationship to the axillary artery.
Okay, perfect. And the lateral cord gives rise to...
The lateral cord is actually formed by the anterior divisions of the upper and middle trunks, and it gives off the lateral pectoral nerve,
Okay.
which innervates the pec major.
Uh-huh. And the posterior cord is formed by...
The posterior cord is formed by all 3 posterior divisions.
from all 3 trunks. And that gives rise to a bunch of nerves that innervate the posterior compartment of the arm.
Huh?
So proximally to distally, you get the upper subscapular nerve, thoracodorsal nerve, which is going to innervate the latissimus, and the lower subscapular nerve.
Perfect. And then the medial cord arises from...
The medial cord arises from the anterior division of the lower trunk.
Okay.
And that gives rise to the medial pectoral nerve,
Huh?
the medial antebrachial cutaneous nerve, and the medial brachial cutaneous nerve.
Perfect. Great. And then those cords then ultimately branch off into the terminal nerves.
Right.
Which are the...
Which are the real workhorses
Yeah.
of the upper extremity. So you have the musculocutaneous, the axillary, the radial, the ulnar, and the median nerves.
Okay, perfect. So that's a nice overview of the brachial plexus. And so now let's transition to talking about, how we actually classify these brachial plexus injuries.
Sure.
So what are the major distinctions that we make?
Well, I think the first thing to think about is location of the injury. We can think about injuries to the brachial plexus as being either supraclavicular
Okay.
or infraclavicular.
Okay, perfect. And so supraclavicular injuries, those affect what parts of the brachial plexus?
So those are going to affect the roots or the trunks.
Okay.
And those are actually more common than infraclavicular injuries.
Okay. And so when we talk about supraclavicular injuries, what's a classic injury that we think about in terms of the root level?
Right. So if you have an injury to the upper trunk, you may have heard of Erb's point.
Yeah.
That's where the C5 and C6 roots kind of come together to form the upper trunk. And if you have an injury to the upper trunk or those roots, you can get what's called Erb's palsy.
Right.
And so classically, patients will have a waiter's tip deformity.
Right. And just explain for the listeners what that deformity looks like.
Right. So their arm is going to hang by their side. It'll be internally rotated, and the forearm will be pronated. And that's because they've lost function of their deltoid, their supraspinatus, and their biceps.
Okay, perfect. And so infraclavicular injuries, those affect.
Those are going to affect the cords
Yeah.
or even the terminal branches.
Right. And those typically occur where?
Those typically occur in the axilla, and a lot of times those are associated with shoulder dislocations or fractures.
Right. Okay. And now another way that we classify brachial plexus injuries is based on whether the injury is preganglionic or postganglionic.
That's right. That's a really important distinction.
Okay. Yeah. So can you just define those two terms?
Sure. So preganglionic means that the injury is occurring to the nerve root proximal to the dorsal root ganglion.
Okay.
So it's really close to the spinal cord. And postganglionic means the injury is distal to the dorsal root ganglion.
Okay. Perfect. And so clinically, how does that actually manifest? Like, how would we be able to tell whether someone has a preganglionic versus a postganglionic injury?
Well, one of the key things on exam is the presence or absence of SNFPs,
Right.
sensory nerve action potentials. So if you have a patient who has a completely flaccid, paralyzed upper extremity, but you can still get an SNFP when you do nerve conduction studies,
Okay.
that tells you that that injury is preganglionic.
Okay. So the SNAPs are present.
That's right, because the sensory cell bodies are still intact
Okay.
in the dorsal root ganglion.
Yeah, that makes sense. And so are there any other ways that we can clinically differentiate?
Yes, there are. So in terms of preganglionic injuries, remember those are root avulsions.
Yeah.
So those are really tough to fix with a nerve graft because you have avulsion of that root right from the spinal cord.
Uh-huh.
You'll also often see that those patients will have denervation of the paraspinal muscles, the muscles in their neck,
Okay.
and they can have pretty severe pain associated with root avulsions.
Okay.
And then depending on the level, if it involves C8 and T1, you can get Horner syndrome.
Oh, right. Okay. And so can you just remind the listeners what Horner syndrome is?
Yeah. So Horner syndrome is a constellation of symptoms. You get litosis, which is drooping of the eyelid.
Right.
You get meiosis, which is constriction of the pupil.
Okay.
And you get anhidrosis, which is absence of sweating on the ipsilateral side of the face.
Right.
So if you see that, that's a pretty good indication that you have a preganglionic injury, particularly at the level of C8T1.
Okay, great. And so what about postganglionic injuries?
Right. So postganglionic injuries, those are going to be distal to the dorsal root ganglion.
Okay.
So the neck muscles should all be intact. They shouldn't have Horner syndrome. And because the nerve fibers that are distal to that injury are going to degenerate,
Right.
you're going to see Wallerian degeneration. You're going to have absent SNFPs.
Okay.
But the good news is a lot of times those are amenable to surgical repair, either with a graft or sometimes even a direct repair.
Okay, perfect. So those are some of the key ways that we classify brachial plexus injuries.
Yeah.
Now, let's talk about epidemiology and mechanisms of injury. So in newborns, what's the most common way that these injuries happen?
Right. So in newborns, it's brachial plexus birth palsy, or BPBP. And there are some risk factors that you should be aware of that can increase the risk of a baby having a brachial plexus injury during birth. So things like shoulder dystocia,
Okay.
gestational diabetes in the mother, operative vaginal deliveries, larger babies, what we call macrosomia, and then if the mother's had multiple pregnancies, what we call multiparity.
Okay.
So those are all risk factors for BPPP.
Right. And so in terms of the level, what's the most common type of brachial plexus birth palsy?
So the most common type is Herb Duchenne palsy, which is an upper trunk injury involving C5 and C6.
Right. Okay. And the good thing about these injuries is that a lot of them will actually recover spontaneously.
Yeah. The good news is the vast majority of babies who have BPPP will recover spontaneously within the first few months of life. And so the initial management is really just observation and physical therapy.
Right. Okay. And what about those that don't recover spontaneously? What are the indications for considering surgical intervention?
That's a good question. And there's actually some debate about when exactly you should operate on these babies, but there are some general guidelines. So if the baby doesn't have biceps or deltoid function by 3 to 6 months,
No.
that's a bad sign, and that might be an indication for surgery. Similarly, if the baby has no anti-gravity movement of multiple muscles in the arm by 9 months,
Okay.
that would also potentially be an indication for surgery. And then a completely flail upper extremity with Horner syndrome
Right.
would also be an indication to consider earlier surgical exploration.
Okay, great. So now let's transition to talking about brachial plexus injuries in older individuals, so not birth-related. So what's the most common mechanism of injury in these cases?
So in older individuals, it's trauma.
Okay.
And we usually see this in young men, and it's often high-energy trauma, like a motorcycle accident, a car accident, something like that.
Okay. And so these injuries much more commonly require surgery than birth brachial plexus palsies.
Yes, that's right. Much more often requires surgery. And the outcomes tend to be better if you can get to surgery within about 6 months of the injury.
Okay. And so what are the different mechanisms by which these traumatic brachial plexus injuries can occur?
Sure. So the most common mechanism is traction.
Yeah.
And you can think about traction either in a downward direction, which might cause an upper plexus injury,
Right.
or in an abduction direction, so the arm being pulled away from the body, which might cause more of a lower plexus injury. And then you also have to consider iatrogenic injuries, so injuries that occur during surgery.
Right. Okay. And so in terms of velocity of the injury, like how does that impact the type of injury that we see?
Yeah, so higher velocity injuries, like from a severe motor vehicle accident,
Uh-huh.
those are more likely to result in root avulsions.
Okay.
So in those cases, we often observe the patient for a period of time, maybe
Yeah.
3 months or so,
Okay.
and do serial exams and nerve conduction studies to see if any spontaneous recovery is occurring.
Yeah. And low velocity injuries, I imagine we manage those similarly.
Yeah, with a similar algorithm. Do your initial assessment, watch them over time, and then make decisions about surgery based on what you're finding.
Right. And so in addition to traction injuries,
Yeah.
what are some other mechanisms of traumatic brachial plexus injuries that we should be aware of?
Right, so you can also have crush or compression injuries.
Uh-huh.
And that might involve that area where the brachial plexus is passing between the clavicle and the first rib.
Right.
And that can happen from a direct blow, trauma to the area, or it can happen from occupational causes or sports. Sometimes there can be other factors involved, like if there's a bony fragment from a fracture, if there's a hematoma, or if the patient has a cervical rib, or even fibrous bands in that area. Those can all contribute to a crush injury.
Okay. And then the other type of mechanism would be?
Yeah, the other type is open injuries.
Right. Okay. And those, thankfully are less common.
Much less common, thankfully.
Yeah.
But with those, a lot of times you can actually go in and do an immediate exploration and repair,
Mm-hmm.
particularly if it's a sharp injury,
Right.
a clean laceration.
Yeah.
We always have to worry about associated vascular injuries with these.
Right. Of course. Yeah. And what about gunshot wounds?
Yeah, so with gunshot wounds, lower velocity injuries might have more temporary nerve dysfunction that can recover on its own,
Mm-hmm.
whereas higher velocity injuries are going to cause more severe nerve damage.
Right. Okay. And so higher velocity injuries we would manage more urgently, I imagine?
Yeah, you might consider going in sooner for those.
Okay, perfect.
Okay.
All right. And so now let's talk about patient evaluation. So when we have a patient who presents with a brachial plexus injury, what are some of the key principles of evaluation, especially for the boards?
Well, one of the big things to remember is that you're often going to have multiple nerves involved.
Right.
And these nerves are going to be injured to varying degrees. Some nerves might be completely transected, others might be in continuity but have some damage. So you really need to do a detailed exam of the entire extremity.
Right.
The other thing to remember is that time is really important in terms of prognosis. So the earlier you can intervene, the better.
Yeah.
Ideally within the first 6 months after injury.
Okay.
And then the patient's age is also important, with younger patients generally doing better than older patients. And then the last thing is to really try to understand the mechanism of injury,
Okay.
because that can give you some clues as to what type of injury pattern you might be dealing with.
Right. That makes sense. And so what are the key elements of the physical exam?
All right, so you're going to need to carefully examine the patient's motor function, sensory function, and vascular status of the limb.
Okay.
When you're looking at motor function, you want to document the strength of all the key muscle groups in the affected arm, and you want to use a standardized grading system. So we typically use the British Medical Research Council, or BMRC scale, to grade muscle strength.
Okay.
And you want to be sure to look for any signs of atrophy or wasting of the muscles.
Okay.
And then you want to assess the range of motion in all the joints of the affected limb, both passive range of motion, which is what you're moving the limb for them, and active range of motion, what they can do on their own.
Okay.
And it's always helpful to compare the injured side to the uninjured side
Right.
to get a sense of what's normal for that patient.
Oh, okay, great. And you mentioned it's important to test specific muscles.
Yes. So knowing which nerve roots supply which muscles is really crucial for your exams. So, for example, you want to test the trapezius, which is actually supplied by cranial nerve 11, but also gets some innervation from C3, C4. And you want to make sure that you're isolating the trapezius when you're testing it, and not just the upper fibers, because sometimes patients can shrug their shoulders, even if they have a brachial plexus injury. And then the serratus anterior is another important muscle to test. That's supplied by the long thoracic nerve.
Yeah.
Then you want to test the supraspinatus and infraspinatus, which are supplied by the suprascapular nerve. The biceps, which is supplied by the musculocutaneous nerve.
Okay.
The pectoralis major, which is supplied by both the lateral and medial pectoral nerves.
Right.
The latissimus dorsi, which is supplied by the thoracodorsal nerve.
Yeah.
The triceps, which is supplied by the radial nerve.
Okay.
And then, of course, you want to test the intrinsic muscles of the hand,
Right.
which are supplied by the ulnar and median nerves.
Perfect. And you also mentioned the importance of vascular assessment.
That's right. You always want to check the pulses distally, so the radial and ulnar pulses at the wrist. And if there's any concern about the vascular supply to the hand, you can do an Allen's test
Right.
to assess the collateral circulation. And if there's any suspicion of a vascular injury, you should definitely consider getting an angiogram.
Okay, perfect. And then sensory testing.
Sensory testing. So you want to assess both light touch and pain sensation
Okay.
using a pinprick.
Okay.
And you want to test two-point discrimination, which is the ability to distinguish 2 points that are close together on the skin. And you also want to check vibration sense.
Right.
And you want to map out all of this in the different nerve distributions to see where there might be deficits.
Okay.
And then there's also Tinel's sign, which is where you tap along the course of a nerve.
Yeah.
And if the patient reports tingling or paresthesias in the distribution of that nerve, that can indicate that there's some regeneration happening distally.
Okay.
But it's important to remember that the absence of Tinel's sign doesn't necessarily mean that there's no regeneration.
Right.
And the presence of Tinel's sign doesn't guarantee that the patient's going to have good functional recovery.
Okay, that's good to keep in mind.
Yeah.
And in addition to the physical exam, what other diagnostic studies are we going to use to evaluate these patients?
Right. So electrodiagnostic studies are really crucial. So electromyography, or EMG, is one of the key tests we use, and that's usually done a few weeks after the injury.
Okay, why is that?
It takes a little bit of time for the changes that happen in the muscle due to nerve damage to become apparent on EMG.
Okay.
And EMG can help us identify which muscles have lost their nerve supply. And it can also give us some information about whether or not the nerve is starting to regenerate.
Right.
And then nerve conduction studies are also really important. And these include sensory nerve action potentials, or SNAPs, which we talked about before. And those are really helpful for distinguishing preganglionic from postganglionic injuries.
Right. So if we do nerve conduction studies and the SNAPs are present, even though the patient has complete paralysis, then that would suggest a preganglionic injury.
That's right. But it's important to remember that the absence of a SNAP doesn't rule out a preganglionic injury.
Okay.
It just means that the injury might be so proximal that we're not able to pick up a signal.
Got it. And then in terms of imaging, what are the studies that we order?
So we typically start with plain radiographs. So x-rays of the cervical spine, the shoulder, the clavicle, and the chest.
Okay.
And those can show us if there are any associated bony injuries, like fractures of the transverse processes of the vertebrae, or if the diaphragm is elevated, which can be a sign of phrenic nerve involvement.
Okay. And then what about more advanced imaging?
So CT myelography is a really helpful study, and that involves injecting contrast dye into the spinal canal and then doing a CT scan.
Okay.
And it's really good for visualizing the nerve roots.
Okay.
And so we can see if there's any evidence of pseudomeningocele, which are these outpouchings of the nerve root sheath that can occur with root avulsions.
Okay.
And we can also see if the nerve roots are deviated, which can also be a sign of an avulsion.
Okay. And so when do we typically do a CT myelogram?
So we usually wait at least a month after the injury before doing a CT myelogram because it takes some time for those pseudomeningocells to develop.
Okay. And are there any other imaging modalities that we might use?
Yeah, so MRI is another option. And MRI is nice because it's non-invasive.
Right.
And it doesn't require us to wait a month after the injury.
Okay.
So we can do that sooner.
Okay.
And MRI can also give us some information about the brachial plexus itself.
Okay.
It can show us areas of edema or hemorrhage, within the plexus, which can be suggestive of injury.
Okay, great. So the standard evaluation of brachial plexus injury, what does that entail?
So a good workup should include a detailed history and physical exam,
Okay.
electrodiagnostic studies, plain radiographs, and usually an MRI.
Hmm.
And then in selected cases, we might also consider doing a CT myelogram or an MR angiogram if we're concerned about the vascular supply.
Okay, perfect. And so before we dive into the treatment of brachial plexus injuries, let's talk a little bit about preoperative management. What are some of the key things that we do for these patients before we take them to the operating room?
So physical therapy is absolutely critical
Okay.
for these patients. And the goal of physical therapy is to maintain passive range of motion in all the joints of the affected limb to prevent stiffness and contractures.
Okay.
We also want to use appropriate splinting to protect the limb
Okay.
and to prevent any further injury from occurring.
Right.
And then later on, as the patient starts to recover some function,
Right.
physical therapy is going to focus more on motor reeducation and strengthening.
Okay. And then what about pain management? How do we manage these patients' pain?
Pain management can be really challenging, especially in the setting of root avulsions.
Right.
Those patients can have really severe neuropathic pain. And so we often use medications like gabapentin or pregabalin
Okay.
to help with that nerve pain.
Yeah.
And we may need to refer the patient to a pain specialist to help us manage their pain.
Okay.
And then in really severe cases that are refractory to other treatments, we may consider neurosurgical procedures targeting the dorsal root ganglia
Right.
to try to alleviate the pain, but that's kind of a last resort.
Okay, makes sense. So now let's talk about the treatment of traumatic brachial plexus injuries. So what are some of the key principles that guide our approach?
Well, the first thing to keep in mind is that these patients often need long-term multidisciplinary care.
Okay.
So we need to involve physical therapists, occupational therapists, pain specialists, and sometimes even psychologists to help these patients through their recovery.
Right. And in terms of initial management, what do we do for these patients when they first present?
So for closed injuries, we usually start with non-operative management,
Okay.
meaning observation, unless there's clear evidence of nerve disruption.
Okay.
So we'll follow the patient closely, we'll do serial exams and nerve conduction studies,
Uh-huh.
and we'll see if any spontaneous recovery is occurring.
Okay. And generally, do we try to reconstruct the entire brachial plexus?
No, not always. So the lowest part of the plexus, involving C8 and T1,
Okay.
those nerve roots have to travel a really long distance to reach the hand muscles. And a lot of times the results of trying to reconstruct those nerve roots are not that great.
Okay.
So often we'll focus on the upper and middle parts of the plexus.
Okay. That makes sense. And so when we do decide to operate, what are some of the decisions that we have to make in the operating room?
Well, one of the big things is deciding whether a nerve is in continuity,
Uh-huh.
meaning that it's still intact but maybe just damaged, or whether the nerve is non-viable, meaning it's completely transected or so severely damaged that it's not going to recover.
Okay. And so how do we actually make that determination?
So we use a combination of intraoperative inspection,
Uh-huh.
nerve stimulation, and nerve conduction studies.
Okay.
So we'll look at the nerve, we'll see if there's any obvious signs of transection or neuroma formation,
Right.
and then we'll stimulate the nerve proximally and see if we can get a muscle contraction distally.
Uh-huh.
And then we'll also do nerve conduction studies to see if there's any signal going across that nerve. And based on all of that information, we'll decide whether to just do a neurolysis, which is releasing any scar tissue around the nerve,
Okay.
or whether we need to resect the damaged portion of the nerve and do a nerve graft.
Okay, perfect. And then what are our main goals of reconstruction?
Right, so the goals of reconstruction are really focused on restoring function.
Okay.
So the most important function that we try to restore is elbow flexion,
Okay, and why is that?
because elbow flexion allows the patient to bring their hand to their mouth,
Right.
which is really important for eating, grooming, and all sorts of activities of daily living.
Makes sense.
Okay.
And what are some other goals of reconstruction?
So we also try to stabilize the shoulder
Uh-huh.
to allow for external rotation of the arm. And then we also try to restore function to the wrist and fingers if possible. And then we also want to try to restore some protective sensation
Okay.
to the hand so that the patient can avoid injuring themselves.
Okay, that makes sense.
Yeah.
And so what are the main techniques that we use to achieve those goals?
Right. So the two main techniques are nerve grafting
Uh-huh.
and nerve transfers.
Okay.
And we often use a combination of these techniques to get the best possible outcome.
Okay. And then in some cases, we may also consider arthrodesis.
That's right. So arthrodesis is fusion of a joint.
Okay.
And so we might consider doing a shoulder arthrodesis in some cases to improve stability and pain relief.
Right. Okay. So can you talk a little bit more about nerve grafting?
Sure. So nerve grafting involves taking a piece of nerve from somewhere else in the body and
Yeah.
using it to bridge the gap in the injured nerve.
Okay.
So we have to harvest that nerve graft.
Mm-hmm.
And some common donor nerves that we use are the sural nerve from the leg
Okay.
and the medial antebrachial cutaneous nerve from the arm.
Right. And so then we take that nerve graft and we suture it to the two ends of the injured nerve.
That's right. So we expose the injured nerve, we cut back to healthy fascicles, which are the bundles of nerve fibers,
Okay.
and then we suture the nerve graft in place. And those nerve grafts can be connected to the cords of the brachial plexus,
Okay.
or they can be connected directly to the terminal branches of the brachial plexus.
Okay. And which one we choose depends on the specific injury pattern.
Exactly.
Okay. Perfect. And you mentioned earlier the importance of intraoperative nerve testing. Can you expand on that a little bit?
Sure. So it's really important to realize that just looking at a nerve intraoperatively doesn't tell us how badly it's damaged.
Right.
So we can't just rely on our eyes. We really need to use electrodiagnostic testing to assess the nerve.
Okay.
And so some of the tests that we can use intraoperatively include somatosensory evoked potentials, or SSPs,
Okay.
motor evoked potentials, or MEPs. And we can also do direct nerve action potentials, where we're stimulating the nerve and recording the electrical activity.
Okay.
And we can even send a piece of the nerve for histologic analysis
Okay.
to look for signs of nerve activity.
Okay, that's interesting. And so how do we use the results of those tests to guide our decision-making?
Right. So if the nerve is conducting well and we're getting good signals on our intraoperative testing, then we might just do a neurolysis and leave the nerve in continuity.
Okay.
But if the nerve is not conducting well, or if there's evidence of a neuroma,
Right.
then we're going to need to resect that portion of the nerve and do a nerve graft.
Okay, perfect. And so now let's talk about nerve transfers. So what are the main indications for doing a nerve transfer?
Right. So nerve transfers are another really powerful tool that we have in our armamentarium. And the basic idea is that we're taking a nerve that's functioning,
Okay.
but maybe not as critical.
Expert speaker.